And case study number 6, immunological disorders. Again, this scenario starts with DC being a 32-year-old white clerical worker who lives with his 76-year-old grandmother, and progresses on from there. Number 1, why was DC diagnosed as having AIDS rather than complicated HIV infection? When you look at the numerous opportunistic diseases that are occurring, the fever, the flu-like symptoms, a number of different things that have occurred, you can see that again, you'd want to have the CD4 count, but chances are that CD4 count is down, and that's why those opportunistic infections are occurring. Number 2, considering DC's AIDS status, what findings are you likely to present when you receive the results of the lymphocyte studies? And again, chances are those are going to be below 200. Number 3, provide possible explanation for DC's rapid conversion from HIV positive to AIDS, because it says that he was diagnosed with being HIV positive 3 months ago and has been under close outpatient medical supervision for the past 3 weeks because of numerous situations. And really the best explanation for that is simply he just lived for a very long time without even knowing he was HIV positive. So he may have gotten infected a decade before, didn't know he was infected, has lived asymptomatic since, and now all of a sudden he's symptomatic, goes in for tests and finds out he's 1, HIV positive, and 2, it's progressed to the level of AIDS, which would be extremely mentally taxing to all of a sudden have your life flip upside down. As DC's nurse, list at least 2 observations you would monitor in relation to each of the following infections: cryptosporidosis, candidiasis, CMV. It says at least 2, but based on where the fungal infections are at, the cryptosporidosis, the candidiasis, and the CMV being in the intestinal tract, that you would base those off of the book. I just guide you back to the book, and you can pick any of the 2 observations for those disease processes. Number 5, given the previous possible problems that DC could encounter, which of the following nursing orders would be appropriate? Label each with A for appropriate or I for inappropriate, and correct the inappropriate orders. Monitor vital signs QH hours. I would actually consider that to be inappropriate because I think that's not frequent enough for long-term care, especially with his fever being 103.5. We'd be monitoring it every 2 or 4 hours probably. Assist with ADLs as needed. That would be appropriate. Keep perineal area clean and dry. Use protective skin cream. That would be appropriate. You want to use the right kind of cream. And chances are, depending on where you're exactly talking about in the crevices, you'd want to, actually I'd renege on that. You'd probably want to stay away from the cream. You'd want to use powders or nystatin, because it could be a fungal thrush or fungal infection with just a yeast infection. So you just clean and dry, boom, and then maybe certain powders to keep it clean and dry. The cream could actually develop the infection more. Regular diet, based on what his intake has been and the fact that they're looking at TPN, and he's not able to keep food or fluids down, I've seen some doctors leave regular diets and just as tolerated, but chances are you're probably going to want to go clear liquids or soft foods or that kind of thing that might be more likely. NPO isn't necessary. Yes, he's having a lot of diarrhea and he's losing a lot of hydration, but you want to try and hydrate as best as you can and try and keep down what you can, but chances are whatever diet order you order, he's not going to be able to keep it down. Monitor lung, skin, abdomen, and urine output once per shift. That's accurate. That's appropriate. You could do it more often, maybe every 4 hours, but depends on the doctor's order too. Maintain complete bed rest. that is not necessary. You are going to allow activity as tolerated. Yes, they might be a fall risk, and you can make them a fall risk, but your best bet is to actually allow them to have as much freedom as possible, so not complete bed rest. Use toothets and soft bristle brushes for oral hygiene. I would say yes, especially as their health status declines. They might be at more risk for bleeding, which then would open them up for infection and that kind of stuff. So yes, toothets and soft bristle brushes. Exclude diarrhea stool from I&O measurements. That's inappropriate, and you would want to include the diarrhea stools because it's liquid, it's mainly water, and you actually measure that liquid stool. And monitor IV site for signs of inflammation. Change site if red and swollen. That would be appropriate, and that's your normal orders for IV. That when it goes bad, you change it. Number 6, DC is restless at times. Because of his muscle soreness upon entering his room, you note that he has pulled out his peripheral IV and is bleeding. How should you respond? By stopping the bleeding and restarting his IV, and educating him on the importance of that IV fluid for hydration. Number 7, cite at least 5 findings that would indicate DC's condition is stabilizing or improving. Those are things that you come up with based on the negative side effect or negative issues going on in the scenario. So diarrhea stool diminishes to 1 or 2 stools a day. Soft stools a day. He's able to keep foods down, keep fluids down. Infection, fever is stabilized below 100.1 or something like that. So no cough, no chest pain, any of those symptoms that were presented, you could just do the opposite of them and make them a positive outcome. 8, what assessment findings would the physician take into consideration when making the decisions to place DC on TPN? And all that has to do with his hydration, his skin turgor, his eyes and nose, his daily weight changes, and watching for his hydration status and lab values. B1 and creatinine, GFR, those can become elevated when somebody's really dehydrated. Hemoglobin hematocrit might become elevated actually when you become really dehydrated initially. So things like that they'll be watching for. Number 9, given DC's grandmother is the primary caregiver, discuss the implications of DC's diagnosis of AIDS. Well, with her being the primary caregiver, she's probably not going to be able to provide the necessary care as his condition diminishes. And so you start discussing that with her and her grandson. 10, would DC require additional teaching regarding his ability to transmit HIV now that he has AIDS? No, he wouldn't, because AIDS is just end-stage HIV. And so the same standards that were in place for HIV are still in place for AIDS. It doesn't change. The level of transmission doesn't change, or the ability to transmit doesn't become increased with AIDS. It's the reverse, where with the infection, you're much more likely to receive infections from other people. So that's the big thing that needs additional teaching. And 11, DC begins to slowly respond to treatment and discharge plans are begun. Identify at least 3 ways that DC's post-AIDS care will differ from his pre-AIDS care. And those can be a variety of different things. The big ones are rest, activity, appropriate levels, nutrition status, diet, stress, and then avoiding crowds and watching for fevers and things like that that you want to much more be aware of as they've developed into having AIDS, progress to AIDS. So that's it for case study number 6. Thanks so much.